If someone has panic attacks all the time, that's all they ever have and they're always about the same, maybe it's just panic attacks. But if someone has panic attacks and then has a big convulsion with no clear reason, those panic attacks may have actually been a seizure that's less severe than a convulsion that eventually evolved into a bigger seizure, and they had no idea that they've been having seizures the whole time.
Going back to the normal brain versus the epileptic brain, how important is it for the EEG to be on the patient whenever they're having an event? Let's say an aura, and by the way, aura, you had mentioned auras, but we didn't classify that for people who aren't necessarily well-versed in epilepsy. When you have a certain taste in your mouth, when you have the staring spells or the blinking, that is considered an aura, kind of a tell of a seizure. So how important is it to catch these events on the EEG when they're actually happening? Let's say juvenile myoclonic epilepsy, where they wake up in the morning and they're tired and they start these little jerks, versus at 2 p.m. when they're not having these jerks. Is it important? Should we keep the EEG on for longer? What do we do here?
Yeah, so first I'll say that what used to be called aura, we really do know are seizures. Those are actually seizures. They're called focal aware seizures. And they're not just like a suggestion that a seizure might come. They're actually a seizure. It's just that they do evolve and develop often into a more extensive, involved seizure, which we might call focal unaware when someone is not responsive normally, versus or generalized in what we call a tonic-clonic seizure, where they may actually lose consciousness and shake. So all of this is sort of you can think of it as a spectrum of seizure activity. And so do we need to catch it on the EEG is a great question. I mentioned that we do those short EEGs, let's say at the neurologist's office, when someone is first being seen for that first seizure. Are we expecting to catch an episode? Is that going to happen? It's very unlikely that that's going to happen. So why are we doing it? Is it a waste of time? The reason is that if someone has epilepsy, their brain is not normal all the time. It's actually intermittently abnormal, obviously, because they have that risk. And that electrical abnormality is something we can pick up at any time. We might not. We might miss it, but we might catch it. And that's why we do that EEG. That has to be balanced with the inconvenience, the cost of watching somebody for days. So we do watch people for days when that becomes necessary, and it does. And in those cases, yes, we really want to try to capture those episodes on the EEG, preferably with video. And if we can catch them, we can be pretty definitive about whether they are seizures, because if they are a seizure, then we're going to see an EEG abnormality, whereas like during the seizure, whereas if they're not, then we're probably, nothing's 100%, but we probably won't.
Yeah. Provoked seizures. You had mentioned that some people have, certain triggers. How do you educate patients on certain triggers? And do you educate patients who've had a first seizure, or do you wait until they've been diagnosed with epilepsy to talk about what triggers might happen?
So triggers can be really thought of in two different ways in the setting of seizures. One is triggers or provoking factors in somebody who doesn't have epilepsy, and then triggers in somebody who does. So let's take the provoked seizure, someone who doesn't have epilepsy. In that kind of situation, it might be alcohol withdrawal. That could be a trigger. Every time they consume too much or they stop having it, or drug use, that can be provoking in somebody who doesn't have epilepsy. Another example would be certain medications. There might be medications that someone takes that provokes them to have a seizure. That could be a side effect of it. That situation is handled very differently than someone who has epilepsy and has triggering factors. So let's think about those. That would be something like sleep deprivation, right? Or the classic flashing lights that you hear about that can cause seizures in some people. Those are also triggers, and they're also provoking someone to have a seizure, but that person already has a predisposition to have them. Yeah. So you educate very differently on those. So in the case of someone who doesn't have epilepsy, or we don't think they do, they have provoked seizures, the education is really about avoiding those triggers, right? So if every time you drink too much, you have a seizure, it's pretty obvious you should stop doing that. It's kind of like the classic, you go to the doctor and you say, my arm hurts when I do that. And the doctor says, then don't do that. That's not a great answer,
Right.
but it is true that if you are using drugs and having seizures, don't use drugs and you're not going to have the seizures. That's provoked. In the case of someone with epilepsy, it's a different education, and some of these things have to be balanced with the best quality of life. For example, is alcohol going to provoke seizures in someone who has epilepsy? It might. But if you are very sort of draconian about this and tell everybody, don't leave the house, don't drink, don't stay up late, don't do just stay home and stare at the wall, you're probably going to have less seizures. But that's not really a life worth living. So you have to balance those factors. But yes, I will educate on what those factors are. For example, it's okay to have coffee in the morning. It's probably not okay to have energy drinks all day. Those are going to provoke your seizures. It's a stimulant. But it doesn't mean you should avoid caffeine entirely. So same with alcohol. It's not necessarily good for you, but you can balance a life that's worth living together with your triggers.
Yeah.
So that's how I would approach that.
I'm a caregiver, let's say, right? And I have worked 2 night shifts, and I'm trying to get another night shift.
Not mine.
I have a seizure.
Yeah.
I go to the ER. What's the likelihood of things that you think about as a patient? Am I going to lose my license? Am I going to be able to drive? Am I going to be able to operate heavy machinery for, all these privileges that are kind of taken away for the sake of the patient? What's the likelihood of the first time seizure when you can really say, here were the triggers, here was the provocation. I did 2 overnights. What's the likelihood of them having to go through those precautions?
Yeah, so this is an international podcast, and we have to remember that, first of all, there's several issues. Let's take driving. Yeah. You have legal, you have ethical, you have moral. These are all, you have liabilities to think about that aren't necessarily legal, like someone suing you. These are all different things, and they handle completely different in different areas of the world. So in the United States, every state has their own laws about driving after seizures. So you have to, as a physician, you have to know your own state's laws. There are states where your driver's license is required to be physically taken away by the physician, and there's other states that don't really have any particular guidance to the physician in terms of demanding that they don't drive. Mm-hmm. What I say is that at the very least, we follow the national recommendation of organizations like the American Epilepsy Society, American Academy of Neurology, and those recommendations are that you shouldn't drive for at least 3 months after you have a seizure that affects your awareness. And to be honest, I feel like that's a good recommendation, even if it isn't a seizure. If you have an event that affects your awareness and could potentially occur while you're driving, you probably shouldn't drive for 3 months, or at least until it's determined the cause and can be avoided, seizure or not. But in the case of seizures, if your seizure is a tiny bit of tingling in one part of your body, that's going to affect your driving much less than a convulsion with complete loss of consciousness. So all of these things are taken into account. All of these things have to be considered, again, as you said, because of the quality of life and the effect that they have on the patient's ability to work and have good transportation. But we also have to balance that with society. And that's where we start to get into the ethical and the moral and all these other questions, which is that it isn't just yourself you're hurting. If you have a seizure, you're also hurting the person that you hit. I've had patients create pileups on the highway, and that's incredibly scary to be on the road and know that that's possible. So we have to, again, balance the person's quality of life and functionality in our society together with society itself. Mm-hmm. And again, that the rules about that vary from state to state, country to country, but physicians do try to balance that together with the rights of the individual and the rights of and safety of others. When it comes to driving, there are also certain regulations that have to be followed. If you're a commercial driver, for example, there's going to be different rules than, for example, if you are a private driver. So that's important, has to be considered. Also, pilots, they have to follow FAA regulations, which typically is you're not going to be flying a plane if you're having seizures, obviously.
Thank God.
So yes. So there are also regulations that need to be followed.
Well, that's great for first-time seizures. And I want to talk a little bit more about maybe they think it's their first time to ever have a seizure, but you do a little bit more investigation and you find out it's possibly not the first time they ever had a seizure. Does that ever come across your plate? Do you ever see patients like that who they don't know, or they might think it's the first seizure that they've ever had, and then you've investigated and it actually isn't? Does that make sense?
Yeah, unfortunately, that happens all the time. And typically, here's kind of a scenario of how that happens. Someone has a big convulsion. They grand mal seizure, tonic-clonic, right? And someone sees it, their family member, someone else, and they say, this is something terrible's happened here. We're going to call 911. And they end up in the ER. And the ER says, has this ever happened before? And the person says, no, this is the first time it's ever happened, or their family member says. They eventually end up at a neurologist, right? That may be me, it may be someone else who's not an epilepsy specialist, but either way, if you dig into other events they may have had, I always ask, are there any other feelings you've had or episodes that come and go? And you can ask, you can be more specific. Has anyone ever said that you stare? Or have you ever had moments of deja vu that seem too frequent than they should be? Funny feelings in your gut. There's so many things that could happen. And I kind of run through these possibilities, and I find that sometimes they've been having episodes like that for years, and they discounted them. For example, we talked about how do you tell the difference between a seizure and a panic attack? Well, I mentioned that there's some overlap there. If someone has panic attacks all the time, and then that's all they ever have, and they're always about the same, maybe it's just panic attacks. But if someone has panic attacks and then has a big convulsion with no clear reason, those panic attacks may have actually been other types of seizures. Not other type, it's sort of a seizure that's less severe than a convulsion that eventually evolved into a bigger seizure, and they had no idea that they've been having seizures the whole time. And how do we differentiate is really going to be something like EEG, and that's unfortunately does happen.
So when you're thinking about the first medications on a patient, we'll go back to them coming out of the ER, them seeing you. How do you determine what medications they need to be on? Are there certain seizure types? Is there a certain requirement that a patient has that makes you lean more towards a certain medication?
There are actually a lot of options. There's more than 20, we'll say, seizure medications. So how does a neurologist or an epileptologist or primary care, how do they decide what to use? And there are actually a lot of factors we look at, and some of them may actually seem pretty minor. But let's start with the big ones. So the type of epilepsy that we're treating is really important. The whole idea behind the medication is to prevent more seizures. So there are different types of epilepsy, and there's different types of seizures, and we're going to try to pick a medication that we hope will work for that type. There are medications, and you might call them broad spectrum, like you might refer to antibiotic as broad spectrum, that might work for more than one seizure type or more than one epilepsy. And we prefer those early on when we're not quite sure about what's going on. If we are have a pretty definitive diagnosis, we may select something more specific. But that's a really important one. Beyond that, you start to get into we want the patient to be comfortable with it, and that there's a number of factors there. One is, how often do they have to take it? Are they taking it 3 times a day? There are some that are still like that. We don't use them. But what about once a day? Are there any that are? Yeah, there are. There's extended release, and there's ones that have a long half-life. You can do just once a day. That is way easier, and easier means you're more likely to take it and not forget to take it. And it's so important with seizures that you got to take your medicine every day. So that's another factor. Another is tolerability to making it easier. We don't want the medication to make somebody feel terrible. If they feel terrible, they're also not going to take it. At the end of the day, it doesn't work if you don't take it, and it's important that it works. Yeah. So So side effects can be anything from some dizziness and maybe some tiredness all the way to some pretty severe side effects, especially some of the older medications and some long-term problems that they can cause. So we try to pick something early on. We're talking about that first medicine. We don't want to pull out of the bag those some of those crazy ones. We want to pick something that we think will work quickly, will be tolerated. Another is some of the things that are maybe a little bit more minor but do end up being important is insurance coverage and access. I have patients that live in the mountains of Colorado where it's not so easy to get some of these medications. They may not have them available. It may take time to get them. And that's very different than something that's readily available. Mm-hmm. And then there's cost, which has to do, again, with that insurance coverage. And insurance may not cover one medication. They may require a couple other medications to be tried first before another medication can be used. So we may have less options for that first medication with some insurances. So these factors really do all play a role. There's also patient preference. Mm-hmm. So someone may say, I've heard about this one. My sister's on it. I'll give you an example. I have a patient who came to me pregnant and had epilepsy and had a twin sister who had gone through pregnancy, also had similar seizures, and had tried a certain medication. And the patient said, I want that same one. She didn't have any trouble. Baby did great. Pregnancy went well. Of course, why wouldn't I do that same one, whether I think at that moment it's the very best or not? If everything went well and they're twins, that may be a good option. So that happens too.
Yeah. Yeah. Super important that I think what you said is that the patient really sticks with their medications, follow the doctor's guidance, obviously, but also feel free to have conversations like that with someone like you, an epileptologist, a neurologist. Hey, this happened to my sister or whatever. I think some patients are a little hesitant to do that, but always bring it up, because I think the physician wants to help you out, and you don't shy away. And I know you, and most neurologists that I know, you won't shy away from, if you are really adamant that won't be a good option, you will say it, and you will give that advice, and hopefully other physicians will as well.
Oh, I think probably some final words is that we have to remember, first of all, that physicians are also patients.
Yeah.
Right? We're all human, and there's how to be a good physician, and there's also how to be a good patient. And I suppose it really depends on who's listening to this. If you're a patient or you're a physician, then I would say that I have different advice. If you're a physician, I think it's really, really important to listen to your patients, both when you're taking a history, especially with seizures, because it could be something they tell you at that last second that's so critical to understanding what kind of seizure they have. But also, some patients may not remember medications that they've tried and did terribly with. And if you really dig into that history, you may find that there may be a better option for them. So listening is so important, but also allowing the patient to guide you. Mm-hmm. We have a very different world today in medicine where we're not so, as used to be called, paternalistic. We really try to listen and be guided, as you said, by the patient in terms of what might work best for them. That doesn't mean that we make terrible recommendations. And I think you need to have an open conversation where you say, here's my recommendation, here's what I'm hearing from you, and let's try to find something that's a good fit for you while not doing something that's harmful to you.
Yeah.
On the patient side, because I've been a patient, we all have, is you have to be a good advocate for yourself. And that means that you have to push that physician, that neurologist who may not have a lot of time to spend with you in the modern age, and you have to push them to take the time to hear your thought that may be critical to your care, because you think it's important, and you want to make sure that they use that information in guiding what they decide is the best therapy for you.
Right. And when you say that when they decide, then it's the patient's turn to listen.
Yes.
So that's a big part of it.
It works
too.
both. It really, you've nailed it. It's a relationship.
Yeah.
And it's teamwork.
Yeah.
And the patients that do the best are the ones that listen to their doctor, and the doctor listens to the patient.
That's right. Awesome. Yeah. Well, speaking of teamwork, did great. Man, I appreciate it. Let's do this again. I think.
Happy to be here. Thank you.
Yeah. Let's do it again. All right. Okay. See you later.